being here. We're just going to give it a minute for everybody to tune in here. We've got a pretty good turnout so far, and we've got some fabulous speakers for people as well. I'd ask that people tuning in, if you could turn off your cameras. Okay. That would be great. Okay, and Benna, we can go live now? Okay.
Yeah, we're live. Go ahead, Chris.
Great. So thank you everybody for joining us. I'm Chris Glover. I'm the MPP for Spadina-Fort York. And tonight I'm joined by the fellow moderator, Kristyn Wong-Tam from Toronto Centre, my colleague, and also by the MPP and NDP health critic, Gelinas. Thank you, Franz, for being here. And by Dr. Andrew Katyuka and Christina Aikler. Anyways, RN Christina Aikler. Dr. Katyuka is an internal medicine resident physician in Toronto at several hospitals. He's a member of the Canadian Doctors for Medicare. And Christina is a registered nurse in downtown Toronto with over 20 years of experience. She is a member of the Ontario Nurses Association, Local 97. And I want to thank all of the panelists for joining us tonight. And a big thank you to Christina for not only attending this town hall on such short notice to replace a coworker, but for doing so right before she had to attend at a shift at her hospital. And I understand, Christina, that you will not be able to stay for the whole event, that you're going to be having to go off and work at the hospital. So thank you so much for coming on such short notice and with such a tight timeline. I'd like to take a moment to give a land acknowledgement before we begin. We acknowledge that we are on the land we are meeting on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis people. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. And we're here tonight because our healthcare system is in crisis. The Ford government has a $44 billion contingency fund that they expect to use for crisis, yet our Sick Kids Hospital is in a pediatric crisis right now, and they're telling sick children and their families that only urgent surgeries are going to be taking place. And the ICU is inundated with patients. The ICU at Sick Kids Hospital is operating at 127% of capacity right now. Our concern is that the government is gutting our healthcare system. The Financial Accountability Office, which is an independent financial office of the government, has found that the healthcare sector is their largest funding shortfall. They spent $1.8 billion less on healthcare than they promised Ontarians they would spend. And we have in Ontario the lowest healthcare funding, the fewest hospital beds, and the fewest nurses per capita of any province in the country. And we've seen that this government has the political will to change course when they're pushed. So the Ontario NDP are calling on this government to stop the crisis, which is leading to the privatization, to repeal Bill 124, to create a centralized procedural referral system. And before I turn things over to MPP Wong-Tam, I also want to announce that I will be attending the Ontario Health Coalition's Hospital Emergency Town Hall. And this event is happening November 29th at 7 p.m. And Sam will share from my office. She will share the details in the chat. So I'm going to turn it over to Kristyn. Kristyn, thank you for being here and thank you for co-hosting.
Thank you, MPP Glover. Thank you, Chris, my dear friend, and also riding cousin, or obviously downtown west, downtown east, doesn't really matter in downtown Toronto. We are really one Toronto. I want to say thank you to everyone for taking the time out of their busy evenings. I certainly do recognize that so many of you have family commitments as well as other societal commitments, but I guess this issue is very important for you as it is for us. And I suspect also that you are here because you know that the healthcare system is in crisis. We're hearing about it every single day in our communities in Toronto Centre. There isn't a single day that doesn't go by where I don't get at least one email or sometimes hundreds of emails depending on whether there's a big burning issue of the day, that people are writing in and sharing their experience. They're sharing their experience about the wait for surgical procedures. They're sharing their experience about family care physicians that they have been using for a number of years who are leaving the practice. They're sharing their experience as health practitioners about how they've given 3 years of their lives, being superheroes for us, defending us against COVID, and then finding themselves at the receiving end of what feels like burnout, but also a government that's not caring, especially when it comes to what MPP Glover has rightly noted, which is Bill 124. So tonight's conversation, I want us to be as open as possible, because we are all friends and neighbors here. I want us to take a moment to just recognize how difficult it has been, the pandemic, number one, but also for all the healthcare workers and everybody else who's given so much to protect us, to keep us safe and to keep us healthy. And I do recognize that we've lost people along the way. And there isn't a single question period in the House where questions are not asked about health. Health is the number one burning issue for most families in Ontario, and I suspect it is for you as well. So I would like to just go through a quick agenda review, because the less talking Chris and I do, the more talking you get to do. But there are going to be some basic House rules that we have to abide by to make sure that we can keep our time and make sure that we can speak to each other respectfully. So everybody you see on your screen, especially the ones who are going to be giving their time freely as a speaker, they're giving their time to us tonight. So let's be courteous to them. Let's make sure that our language is going to be nothing but respectful. And even if we have disagreement, that's okay. Well, let's just make sure we hear each other as much as possible. So tonight's presentation is going to come from a number of esteemed panelists, as Chris has noted. Some of you have submitted your questions in advance. So we were able to ask you to give us your questions, and we've now curated them based on the theme of popularity. And so we're going to try to get through as many questions as possible. And hopefully you'll get to hear the answers as our speakers respond to them. Our speakers are subject matter experts. They certainly have much more experience than I do in healthcare, so we're looking forward to hearing from them. So are we ready? Yeah, buckle your seats. Okay. So my first question is we've also themed them. So we wanted to make sure we can somehow curate the experience so you can actually get your questions answered under a theme. So our first theme, if I can call it that, is around privatization. So we are blessed to live in Canada, best country in the world. Medicare is something we all probably take for granted in some ways, but it hasn't always been that way. So before World War II, there was no universal healthcare. Everybody had to pay, and healthcare was largely delivered privately. So over the years, we've actually seen healthcare become much more universally accessible. Not everything is covered, but certainly a lot of it is. And now we're seeing a trend where we're going back towards privatization. So I guess my first question is, for the speakers who are here, do you think that this government is intentionally, and this might be not entirely a fair question, but it's also because we're seeing it coming in the questions to us. So I'm going to sum it all up. Do the speakers believe that the government is intentionally decimating healthcare to build a case for privatization, because the trends we see are there? And what has the government specifically mentioned doing, and how do we stop it? So I'm going to direct my first question to France, if I may, MPP Gelinas from Nicobelt. If you can take the podium, the imaginary podium, and give us a reply.
Oh, absolutely. So I agree with you, Kristyn. Medicare is a program that defines us as Canadian. The care we need is based on our needs, not on our ability to pay. We can go into any hospital in Ontario. We can go see any physicians in Ontario, and it doesn't cost us anything. We are covered by Medicare, whether you're a newborn without a penny to your name or the wealthiest person in your community. You will get care based on your needs, not on your ability to pay. But we have seen this movie before. Previous government do that before. Some of you, my age or older, will remember when Mike Harris was in power. It was the last conservative government that we had. And they privatized our home care system and really started a big push toward privatizing of our long-term care system. And it was pretty much the same. Our home care system was delivered by the not-for-profit. They underfunded it, didn't respond to the need. And then how do we fix this? We bring in the competitive bidding, and they brought in for-profit healthcare. Now our home care. Now our home care system is basically dominated by big, mainly American companies that have the contracts to deliver home care. They fail more people than they help every single day. So your question is, this is a pattern that we have seen before, where the services that people need in order to stay healthy, to stay in their home, to feel respected, get underfunded to the point where people are so disappointed. It doesn't meet their expectation. It doesn't meet their needs. And then they come with, oh, the private sector will do things better, faster, cheaper. And people say, well, we'll give it a shot because what we have now is really not good. The private sector does not do things better, faster, cheaper. Ask anyone in the healthcare system if they think that home care is better now than it was. Ask anybody if they think that the private for-profit long-term care home are better than the not-for-profit. And the answers are clear. Healthcare should be based on your needs, not your ability to pay.
Thank you so much, Franz. Thanks for being here, and thanks for that answer. The next question, I don't know who to direct it to, so any of the panelists, if you would like to answer this question, just raise your hand. During the height of COVID, I had cataract surgery at Kensington Eye Institute here in Toronto. Everything was covered by OHIP. I experienced no waiting list. During the procedure, I marveled at the efficiency, the professionalism, the excellent care, the friendliness of the staff. Presumably, the Kensington Eye Institute is a private corporation, but if all patients with OHIP are treated at no cost themselves, how can this be an unacceptable alternative? Okay. Is there anybody who'd like to take this one on? Andrew.
Yeah, so thanks so much for that question. I think kind of even tying in the previous question as well, when we talk about the general trend towards privatization, we need to be very careful how we discuss the different topics. There's two different sets of issues here. Number one being an increase for private pay, which really involves allowing individuals to pay out of pocket for services that are typically provided under our OHIP system. So that, if we think about it kind of from practical examples, is really going to an organization like Maple that's providing virtual care, paying, getting people to pay out of pocket for services to get a service that really should be insured under our healthcare system. And then secondly, the second part of that is really using public funds to help facilitate private investor owned delivery. And that's kind of using the public purse to subsidize spots in a long-term care facility that is really privately owned and is generating profits for shareholders. Now, with the Kensington Eye Institute specifically, it's a very unique model of care where really public funds are using are kind of going towards an ambulatory center that's nonprofit, where the incentive is really not to provide and generate profits for shareholders of Kensington Eye Institute, but to provide Ontarians with very good comprehensive vision care. And that model of care is actually a very successful model. And the Ontario Medical Association has actually put out a similar solution of focusing on these ambulatory health centers that are integrated in our publicly funded healthcare system to help reduce the backlogs in surgical care. But we have to be really, really careful that we do not kind of equate this with private for-profit corporations also providing this type of care. This is specifically using kind of publicly funded solutions in our public healthcare system to really help Ontarians get better care.
Okay, thank you. Chris, Franz, you want to respond as well? Go ahead.
Just if I could add, Kensington is actually one of the few they call independent health facility. That's how the government fund private clinic. They're one of the few independent health facilities that are not for profit. I'm not surprised at all that they got excellent care and their energy are there to provide good quality care, not to make money. And it shows in the quality of care that they offer.
Thank you so much. Kristyn, over to you.
Thank you very much. And thank you to everyone for your contributions so far. We're off to a great evening. Coming back to obviously we're on the theme of privatization, and I think about, the father of public health care in Canada, Tommy Douglas, and what he originally envisioned back in 1947 in Saskatchewan when the program was first developed. And I think about, over that period of time, how it has expanded across Canada and where we saw the expansion of coverage. But now we're seeing something different, is that sort of contraction of coverage. And then, of course, this blended model that seems to be sort of creeping across, and now perhaps it may be accelerated. Because profits are so much part of privatization, is really about extracting money out of the public system and into the private hands. I'm just really curious, especially for the push around privatization right now, when it comes to publicly funded healthcare, for those doctors and those private practitioners and the big companies that are coming in looking for profits, what is the number one reason that they're against publicly funded healthcare? Is it because that they believe it limits what they can charge in the healthcare setting? What is the big motivation that drives them against publicly funded healthcare? Andre.
Yeah, and speaking for myself as a physician who practices internal medicine and admits patients to hospital regularly here in Toronto, I think that a lot of the push from a physician perspective for privatization is really, I think, what Franz alluded to was the fact that a lot of people believe that the current system is not working. So why not try to see what increasing privatization can do for the system? But realistically, when we look at the evidence, and our organization, for some of you who are not familiar, the organization that I represent, Canadian Doctors for Medicare, we're really a nonpartisan group that advocates for public solutions and to bolster our publicly funded healthcare system. And we really rely on the evidence to support a lot of the proposals that we put forward. And there are a number of myths of privatization that I would love to dispel for the audience. Is that number one is that there's this idea that privatization and increasing the amount of private money in healthcare really alleviates wait times in the public system. And really, that would work, but we only have a finite pool of resources. We only have a finite pool of physicians, a finite pool of nurses and physiotherapists, and so on and so forth. And when we kind of create a dual system where you have private access and also public services being accessed through the public system, you get this idea of cream skimming, where physicians and nurses will leave this public system to go into the private system. And a really good example of that is Australia. They implemented a dual system in 1997 that combines kind of a private for profit model and then also a publicly delivered healthcare system. And really, they have two-tiered outcomes in their system. Right now, if you look at the rates for cataract surgery and wait times for cataract surgeries, for coronary artery bypass surgeries, for joint replacement surgeries, they're much, much higher than our wait times in our publicly funded healthcare system. Not only that, but I think a more troubling statistic is really, if you look across the socioeconomic spectrum, the lowest SES patients actually have a 37% more likelihood of dying of cancer than counterparts in the highest socioeconomic access. And that really just is borne out by the fact that people who have more money can access these services in this two-tiered model. And then secondly, there's this idea that when we think about the free market, that if we increase the demand and competition to provide healthcare, will just spur innovation and competition. But really, that's predicated on the fact that healthcare is similar to a consumer good, but it's not. Healthcare itself is really, and when patients get healthcare from practitioners, they really rely on trust of their physicians to help them navigate them through the healthcare system, because it's very challenging. And as a result of that, when you increase profits and you kind of create this idea that physicians may be motivated by profits, you really have you have the potential to really undermine that kind of relationship. And furthermore, I think when you think about regular consumers, patients themselves are fundamentally in a vulnerable position. They're seeking healthcare in moments of their life when they're most vulnerable, and subjecting them to this model of care in a free market system is really not that beneficial, and it doesn't actually lead to the outcomes you would expect in a more free market. If you think of healthcare as more of a commodity, like the free market, and some of the proponents do.
Andrew, thank you so much for dispelling some of those myths. It is really important. It speaks to the nature. And I think one of the issues that we have in Canada is that we've had public health care through most of our lifetimes, for most of us on this screen. It came nationally in 1965, so we've never lived without it. But if we look at our American neighbors to the south, we see they're paying a lot more for a lot less service. And it's just a horrific situation because many people don't get access at all. Let's see, our next question is, how could privatization benefit the general public without causing harm to those needing care? I'll open this one. Christina, would you like to take a question? Would you like to take this question?
You're on mute, Christina.
Yeah. And while she's unmuted, I'll just say there is an ongoing chat a discussion going in the chat, and plantar fasciitis seems to be the dominant subject right now. And the need for physiotherapy. So if Christina, if you want to throw in physio into this comment, go ahead and answer.
Well, I'll speak for some of the nurses I speak with in my role at the moment as a return to work specialist. I'm speaking every day with nurses from all over my hospital in the downtown core, and I'm getting a lot of feedback from these nurses who are not happy with privatization, and I think they're concerned that while for some privatization may be an efficient method of healthcare or a system of healthcare, it's not for everybody, and I don't think that's going to be fair since it's not for everybody. It's not fair. So, and I think the other concern I have is that these privatized hospitals will have different pay salaries. And I think that some of the nurses are thinking that, they're concerned that some of their colleagues will be moving there because of the increased salaries. And then that is going to draw from the public health system that we have that we have now in Ontario.
Can I ask you a supplementary question on this?
Absolutely.
One of the things that we're seeing in the media is that a lot of nurses are leaving their public hospitals and going to these private for-profit agencies. And then they get more flexible hours and they get higher pay, but the cost of the hospital is exponentially higher, 3 or 4 times higher per hour. What are you seeing that trend, and can you comment on it?
Well, we're having a lot of problems, especially in our ICUs. We're finding that because of the low numbers of staff that they have, what's happening is that they're having to go to other agencies, using other agency nurses, and when they arrive to their units, they're actually paid substantially more than the nurses who have been working there for 10 or 20 or 30 years. And now they have to, work with those individuals during that shift. And there's some resentment that's going on there. But on one hand, we look, well, maybe they have worked there, maybe they've worked somewhere else and they've left their public health system of work and gone into, a private agency, and they're making more money. And what can we do about that? There's nothing, we can't control that. But if the hospital is going to continue to use them, then this is going to be a problem. We're also, anyway, that's it. Yeah.
Okay, thank you, Christina. Over to you, Kristyn.
Thank you, Chris. I appreciate that. Christina, I'm going to direct my question to you because I know you have to, you can't join us for the full session, and I want to make sure I get this question over to you. And then anybody else can answer it as well, because I feel like this is the golden ticket question, just so you know, get very excited about this. because it's the same question that comes up at question period all the time. And the question is, what is the first thing this government can do, the government in power can do, to immediately improve ER wait times? We've all heard the stories. It's more than 10 hours. It's more than 24 hours. Some people are waiting in garages, in hallways. It's everywhere. What can this government do to improve ER wait times?
You know, people think that this is a very complicated issue, but it's not. It's very simple. Decrease the workload so that we can have more nurses available. And number two, increase hospital funding. It's not that complicated. It really isn't. And we can talk about those topics for, you know, a lengthy period of time, but in this meeting, or for this town hall meeting for tonight, you know, we can leave it there. But that really is what we really need. We need to see, the nurses are completely overwhelmed. We were overwhelmed before COVID. No changes were made. Mid-COVID, the anxieties of the nurses continued to escalate. No interventions were made. No extra staff were provided. And as a result, you know, sick time was increased, et cetera. And of course, you know, we could talk at length about the increase in hospital funding and why we haven't received that, why it's going to why it's divvied up in you know, to other areas.
Christina, thank you. France, as our health critic, would you like to answer that?
I would say a lot can be done to bring nurses back to our hospital. The number one issue that I hear is that after 2 years of pandemic, after 2 years of working really, really hard in difficult condition, in dangerous condition, at the beginning of the pandemic, we did not even really know how this disease was spreading, but we saw a lot of healthcare workers get sick, get COVID. Some of them are quite serious and some of them died from it. It's been tough. They are human beings. In order for a quality care relationship to be there, they need to be at the top of their games, but they're burnt out, they're exhausted, and they feel disrespected by a government who refuses to take away Bill 124. Bill 124, when the pandemic started, Bill 124 should have gone out the window because they were embarking onto a really, really difficult time where we need all hands on deck to support them to do their work, not only nurses, but physicians, physios, OT, speech labs, everybody needed to be supported. But we saw none of that. So not only are they burnt out, they're discouraged, they don't feel respected, and they say, I'm not risking my license, I'm going to sit at home.
Thank you.
I would agree with that, if I may. I would agree with that 100%. Nurses are feeling very exhausted, very worn out, not respected. And repealing Bill 124, at least we would know that somebody is listening, because we just feel like now nobody is listening.
Thank you. Andre, I see your hand up.
Yeah, I 100% agree with that. And many of my physician colleagues we're advocate for repealing Bill 124. It's fairly low-hanging fruit for this government to encourage nurses to stay in our system. But taking it back to your original question about the biggest issue that is leading to the ER wait times and what the government can really do actionably to decrease wait times in the ER, I think comes back to the family physician shortage in primary care. There was a report recently put out that 1 in 5 Ontarians by the year 2025 will be without a family physician. And the main issue with that is that when you do not have a primary care provider, be that a nurse practitioner or a family physician for routine care, the emergency department becomes a walk-in clinic, a 24-hour walk-in clinic, where you go for that mental health check, that prescription refill, or when you have kind of what the emergency is built for, more acute events that need to be addressed in the hospital setting. So I think that the government really needs to focus on improving team-based primary care and needs to increase funding for team-based primary care in order to ensure that Ontarians really have access to a primary care provider in a team-based model. They also need to really focus on reducing the administrative burden for physicians so they can actually provide direct patient care. And I think one way to really do that is to centralize the referral process, as Chris had mentioned. There's a huge level of burden placed on physicians to find the appropriate referrals and to ensure that their patients get care. And many of these patients then end up, instead of, for example, waiting for a CT appointment that was, you were sent to one hospital where there could be a bit further away, could be another appointment that was available. They end up just coming to the emergency department to get that CT scan overnight, which really puts a huge strain on physicians in the emergency department. And then another problem that we are finding is that with this expansion of virtual care, during the height of the pandemic, especially for-profit virtual care, standalone virtual care, where you are able to log on and see a physician kind of on the computer, but when that physician doesn't have an office to actually do a physical exam and see you in person, they just bill OHIP and then also send you to the emergency department to get the actual care you need. And there needs to be regulation and legislation put in place in order to limit that and prevent a lot of these private companies from utilizing the system and further burdening our emergency departments. So those are the two main things that I think this government can really do that's actionable to improve wait times.
Okay. And thank you for that response. And there's quite a discussion going on in the chat. I welcome people to join in there. Janet just said to you, Andrew, thank you. It's really not rocket science how we solve this problem. And Naz, I fully agree. It's incredibly upsetting that this government, was calling people healthcare heroes and then treat them so poorly. It's just, it's really quite shameful, and we need to and that's what this meeting's about. This is about, talking about how we protect our healthcare system and how we protect the healthcare workers within it. So the next question is, and I'll open this to anyone. What is your opinion on the difficult and costly route for international health students to study and become licensed in Canada? Can immigration standards for healthcare workers be relaxed to encourage more people to come to Canada? And I'll open this to anyone. Just raise your hand if you'd like to respond, any of the panelists.
If I may.
Yeah, and to Hani, we're just letting the panelists respond tonight. Thank you. Go ahead, Andrew.
I can briefly talk about that as somebody who recently completed my medical training here in Canada. I think, one of the biggest issues for voters, especially to understand, and I think the reason why this issue is so pervasive is that the training pathway for physicians specifically is very, very complex in Canada. And back in the day, it was actually, I think in Premier Wynn's government, there was an increase in the number of enrollment for physicians to medical school, which on the surface would mean, you have more medical students, you have more physicians. But at the same time, the resident positions where we actually need to train in order to actually become practicing physicians was not increased in the same amount. And then you had these individuals who were getting trained as physicians even in Canada, but they couldn't actually practice medicine because they couldn't match into these different specialties. And then furthermore, a lot of Canadians have to go abroad to do training elsewhere because of the competitive nature of medical school admissions in Canada, across Canada. And they're finding that it's incredibly challenging to come back. And I think the government needs to have a better health human resource strategy to encourage some of these Canadians to come back when they come back to Canada, to encourage them to practice in maybe more underserviced regions in Ontario, in other provinces across Canada, to give back to their communities while also being able to gain the skills they need to practice as independent physicians. And there needs to be just more incentive for these individuals to be able to come back and function in this capacity. But it is a very challenging issue to tackle, given the fact that we have even for Canadian graduates who are practicing here, there's a great shortage for residency spots across Canada.
Thank you so much. Kristyn, over to you.
Thank you very much, everyone. This has been a lively discussion. I think it's going to get even livelier. I have a question that is perhaps on the tip of controversial, but I'm going to ask it because I think it was it has come up in conversations I've had with constituents. I'm sure it's come up probably in conversations that our health practitioners have had with their own patients. So the question, and it really is to anybody who wants to answer it. The question is, can the government be sued and charged criminally for deaths due to the lack of access to emergency healthcare at hospitals? Are there any provisions in the Canada Health Act to put a stop to what they're doing? This is obviously a question that's stemming from just people being frustrated and mad to the point that they're just saying, can the government be charged for murder or negligence in this case?
I could try that one. I will say probably not. The hospital that the patient was brought to and did not provide the care, they can be sued. So can everybody who was on shift at that particular time, the physicians, the nurses, etc. Could sued. I don't know, but brought to court for sure. But I have never seen it brought a step further. Hospitals are the responsibility of the government because I have never seen it. But I'm not a lawyer. I'm a politician. But I've never seen it.
Yeah, thank you, Franz. I know that was probably going to be a very tricky question. It reminds me of the concept that we've all heard about recently, especially when it comes to political decisions resulting in harm and death or neglect to people, social murder. So even though we're not as a politician, you're not a lawyer in this case, we do make decisions, not you and I, because we're not in government, but decisions are made by those in government who can have devastating effect. So that was my question. If no one else is wanting to take that one on, I understand. Chris, I'm going to pass it back to you for the next one.
Okay, I'm going to direct this question at you, Christina, because I know you're running short of time and you got to get to the hospital. What can be done to assist and support primary care nurse practitioners in Ontario to establish their own primary care practices in order to decrease ER visits and provide upstream preventative care? We require flexible funding models to self-start our own practices. So I think there was a partial answer in that question too.
Yeah, well, to be completely fair, as I'm not a nurse practitioner, I'm not sure that question really would be best answered by me, and I'm sure that somebody else may have some better insight on that. So if I may, I'll defer that one.
Okay, Franz, I saw your hand up.
The nurse practitioners were at Queen's Park today.
Yes.
And they came to address specifically that issue. So there's two directions that they like. The first one is that we have this model in Ontario called the Nurse Practitioner-Led Clinic. This is a clinic that is directed by nurse practitioner that gives primary care access to people who are unattached. You don't have a family physician, you don't have access to primary care, you can go to a nurse practitioner-led clinic. They actually started in Sudbury, in my city, the very first one. So we have 25 of them in Ontario. So the first ask of the nurse practitioner is there are right now 8 communities who have put requests for funding who would like to be able to open their own nurse practitioner-led clinic. They're mainly community where they have not been able to have the service of a family physicians for many, many years. And they would like to have access to primary care through a nurse practitioner-led clinic. So that was their first ask. Their second ask is that of the 25 nurse practitioner-led clinic that exist, again, they are in areas of our province where there are no family physicians, but they are still long wait list of people who don't have access to primary care. They would like more nurse practitioner positions to be funded in those existing clinic. And believe it or not, even where I live in rural Northern Ontario, we have nurse practitioners right here, right now in Ontario that train in Ontario University that are underemployed and would love to go work in those clinics.
Okay. Thank you. Kristyn, over to you.
Thank you, and thank you for that answer. There's a lot of individuals on the call, as well as constituents who have written in, and this is a question I think that probably could be placed before any of our speakers. But the question is really, as an individual, so someone who feels like they don't have a lot of power, every day they read about the headlines that are not very, optimistic. It's getting gloomier and gloomier, especially as the flu season upon us, and we're seeing another wave. So my question is, what can individuals do to stop healthcare privatization, and what can they do to advocate to support their healthcare professionals? What can they do to advocate for themselves as patients to make sure that they have access to better healthcare? I'm going to start with Christina, and then I'm going to ask the doctor to answer.
Thank you. I think, the first thing is the wearing of masks. I think that the ICUs now that are what we call seeing a lot of what we call doubles, where nurses are now covering 2 patients at a time, where, in the past, they've always only had 1 patient, and now doubles are becoming more than normal. And I think that if the general public would consider wearing their masks more often, I would have liked to have seen a mandate on that. But of course, as we know, that didn't happen. So I think that would really help us nurses, help all of us in the healthcare setting to manage our patients better, or to manage people coming in better. So if folks could be wearing their masks, that would save us a lot. I do believe that masks are shown to be effective. I've worn them during COVID, and I've worn my mask constantly at work, as my colleagues have, and they've proven to be effective against fighting and COVID. And so if we could just have folks doing that, I think that would go a long way to helping us at the hospitals.
Doctor, would you like to answer that question? What can individuals do to stop
Yeah.
privatization of healthcare?
So I think, I reflect on the conversations I have regularly with my patients in the hospital, where I really try to have at some point a discussion with patients how to empower them to advocate for their own health needs. And similarly, when I reflect on that, I think about broadly constituents and Ontarians in general. I think the best way to fight back against privatization and the encroachment of privatization is really understand the facts, understand these myths, understand the facts that exist about why privatization does not work, and really have these conversations with your loved ones, with friends, in order to kind of create a movement behind this topic. And then use kind of those, when you're armed with that information, really advocate directly towards your members of provincial parliament. Let them hear your voice, let them understand where you're coming from, because I think, like you mentioned, when there's pressure put on the government, they tend to change their positions many times. And I think that really having the right information, really understanding the facts, and then also advocating directly is really the best way, and making sure, especially in a non-election year. In an election year, go out and vote. And that's where the kind of your biggest bang for your buck is.
Thank you, Doctor. I'm going to suspect that Franz would like to answer this.
I'm just going to add, I agree with what's been said. I'm just going to add to this that the Ontario Health Coalition is having some town halls where they do some information as to what it means and how it's being done, and add your name. At the NDP, we also have a petitions, and a petition is something that we can read in the Legislative Assembly in front of everybody hears it, and it mandates a written response within 24 legislative days. So we force the government to give a response, and in writing, that we can certainly share with you. From the response that we get, it sorts of give us clues as to how they intend to do this, what they agree to, what they don't agree. So people signing petition, it works. The government hears that there are hundreds of people opposed to privatizations when the MPP reads it in the House, and the fact that it forces a written response is also something useful.
Thank you. Thanks so much, Franz. Thank you, everybody, for those responses. So I just want to emphasize one thing, Christina. You were asking people to wear masks, and I think that's something very simple that we can all do, and not just to protect ourselves, but just to protect the people around us and to protect our healthcare workers. So thank you for asking that, or for mentioning that. If other actions that people want to do, there's a petition that we have that Franz mentioned. Sam Hamilton from my office just posted the link in the chat, so you can sign up there. Also, Kristen mentioned that the Ontario Health Coalition is also having a town hall. We'll put the details in there. And I just want to say to Terry Lynn's 4-year-old daughter, was mentioned in the chat. She says hi. We say hi back to you, Terry Lynn's 4-year-old daughter. And I want to just go back to a comment in the chat from Jane. And I'm just looking for it here. And I'll open this one. Christina, if you want to answer this one first, because I know you have to go soon. It's about the accountability and about the workload. And she says, this is the problem, why there is an exodus from healthcare. Individual practitioners are held accountable for negative outcomes to patients when they have no control over their workload, where they cannot possibly meet the patient care needs. Is that something that you're finding in your workplace? Are people leaving because of this responsibility that they can't meet?
With a short answer, absolutely.
Yeah.
Yes. As I said earlier, I speak with nurses from all over the building, and every day I'm hearing from someone that they can't manage. They would like to go to, say, for example, a part-time position that's not been granted. They would like to leave on a temporary basis to continue their education, which is not being granted. And they have family members that they need to attend to, personal matters of their own that they need to attend to. So they're looking for, temporary leaves, education leaves, as I said, and they're not being granted. And I'm not sure that I understand why. As a result of the overwork and the anxiety that they're facing on top of all of this, nurses are leaving, and it's mostly the older nurses, the more mature nurses, the nurses who have been there for some time, who certainly take the lead on most shifts, who have the experience, the knowledge that a nurse, a brand new nurse, certainly cannot have and will not have for some time. And so because of that, we're finding that we're getting, I spoke with a nurse today who told me that she was working for an agency. She went to work in a hospital setting. When she arrived, everybody there was from an agency, and she was the in-charge nurse for the night. So, I mean, that just tells you where we sit. That's just one example that came to me today, that a nurse that called me, at home and was concerned about this topic. And so we had to have a conversation about that. So, the healthcare system is in the biggest crisis. We were in a crisis before COVID. We had every opportunity to get this right, to fix it, to assess it, to restructure it all. And it didn't happen. During COVID, we also had opportunities. It still didn't happen. I just don't think that this government is going to be doing anything to help the nurses. And I think that we really do need to see some major changes. The structure of the whole system has to be revamped, in my opinion. And from there, I think that we can look at some positive outcomes for nurses, for patients, most importantly, because that's what this is all about. It's all about the patients.
Yeah. You know what, Christina, thank you so much for that response. And thank you. I don't know if you have to leave now, but thank you so much for being here. And, it is something like we are here because all of us are concerned about our public healthcare system. And all of us want to advocate, for the funding that you need, for the, funding that we all need for a strong healthcare system where workers are treated with respect and where patients get the care that they need. So thank you so much for that. Andrew, I'll turn it over to you.
Yeah, just to kind of piggyback off some of the comments that Christina had made, I think another very interesting observation that I have found in recent months across not only physicians but nurses, nurse practitioners, social workers in the hospital who are practicing in the hospital, the impacts of Bill 7 on burnout have actually also been really underappreciated, because realistically, for those of you who are kind of not fully aware of Bill 7, is really this a bill that kind of forces elderly patients in hospital who are not necessarily appropriate for being in hospital further and awaiting long-term care and things like that, forcing them into a long-term care home where there's a space that might be outside of their community, or forcing them to pay about $400 a day in the hospital. And we have to relay this information to these to our elderly patients, that it's either you leave to this long-term care home that's not in your community, far away from family, far away from resources, or you have to pay this money. And it gives us, as physicians, a significant kind of moral dilemma, because we really don't agree with this type of kind of model of care that we're providing and kind of pushing this on patients, but we really don't have many choices. And then ultimately, our patients kind of look to us and think, this is that the physician or the nurse practitioner or the social worker is driving them out of the hospital and separating them from their communities because we want to save money, which is not necessarily true. And it's a huge, drain on our morale every single day we're at work, especially where I practice on the internal medicine ward, where predominantly we admit adults, many of them elderly, to hospitals. So it's a big challenge, and we really want to advocate for the government to repeal Bill 7.
Okay, thank you so much for bringing that up, Andrew. Kristyn, over to you.
Yes, thank you. My parents have just recently lost their family physician. They've had the family physician for close to 44 years. He was retiring. My dad is 83, my mother is 73. And my story, and their story, I should say, which is now my story, seems to reflect many others who have come forward, is that they've lost their family physicians. They're now in a position of the impossible task of finding someone new. And they've been now looking for about 3.5 months, and they're not finding anybody. So I know this is a very common theme, but we're going to ask the question because it needs to be asked. What can we do for those individuals who've lost their family physicians? Doctor, could I start off with you?
Sure, it's definitely a very challenging topic to kind of find a solution for overnight. But I think, more broadly, when the solutions that kind of physician advocates propose across Ontario is really more focused on a long-term health and human resource strategy. And that really relates to, number one, recruiting more family physicians. Year over year, more and more graduates from medical schools across not only Ontario, but across Canada are not choosing to go into family medicine. And that's because family physicians, unfortunately, are really shouldering the challenges of really in the crisis in the healthcare system. And they're doing this largely alone, kind of in private offices across the province, not functioning in team-based models where they don't have the support of social workers to help with mental health needs of their patients, from dietitians to help with kind of nutritional needs for their patients. And the government is not really doing much to address that. So number one, it's really expanding this more team-based approach to primary care. Number two, it's really incentivizing medical graduates to practice in communities like in Northern Ontario, in Southwestern Ontario, more rural communities that are really in need of physicians. And that can be through not only financial incentives, but programs to help reduce the medical debt burden that trainees have as well. But also simplifying the process for some of our international medical graduates to practice in our healthcare system. And ultimately, I think on a more broader scale, it's really advocating, the provinces need to get together and advocate for a national licensure for physicians in order to facilitate kind of movement of human resources to more underserviced communities. And I think that those are kind of more long-term solutions that need to be implemented. But overnight, unfortunately, it's very challenging for these for patients who do not have a family care provider. I think we need to expand our nurse practitioner kind of models of care as well, especially in communities, once again, that are more underserviced. We have to be innovative and flexible in how we define primary care, and we need to really just work within the system that exists right now, with the ultimate hope of building a better system that will serve our patients in the future.
Thank you. Thank you for that full answer. Franz, would you like to take a stab at it?
I agree with everything that has been said. The only little part that I would add is that there are models of primary care that exist in Ontario. We use them lots in Northern Ontario, where we've always had difficulty recruiting family physicians. So we're talking about community health center, Aboriginal Health Access Center, nurse practitioner-led clinic, and some community-based family health teams, where when you become a patient there, you will be assigned to a family physician, but you become a patient of the community health center. If the physician leaves for one reason or another, it is not your job to find a new family physician. It is the job of the administration at the community health center to find a new family physicians to come to that health center or Aboriginal health center or whatever, where you get your primary care. But the rest of your team is there. If you're diabetic and we're talking to the dietitian, she's still there. You had mental issue, you were talking to the social worker, she or he is still there. The nurses are still there. The nurse practitioners are still there. So as recruitment of physician is difficult in Northern Ontario, where I live, those team-based model allow people to continue to be cared for, continue to have their medical chart in the same place, in the hope that a new physician is recruited as quickly as possible. Those also help.
Thank you. Thank you both. Chris, over to you again.
Okay, thank you. We've got a couple of questions that were sent in beforehand on mental health and homelessness. I'm going to ask one of those questions now. And I can't verify the information that's in here, but one cost-saving measure is early intervention for people living with schizophrenia. And I can speak with some experience of this. My brother has schizophrenia. But I don't know about this number. They are fewer than 2% of our population, but by far the most expensive patients. Can this help stop the revolving door and be proactive? Is there a way to stop the revolving door and be proactive and help these people off the streets and into life-saving medicines? So is there greater care? And one of the things for people with schizophrenia, and I've met many people on the streets who have schizophrenia and who are homeless. And the question is about, can we realize the cost savings if we actually provide them with homes and the medicines and things that they need? Would anybody like to take on this one?
I think, once again, when we kind of very broadly speaking, in Ontario, largely in Canada as well, we don't really, I find that we don't focus enough on preventative health. We really have a health illness model where we are very happy to, not provide patients with the small amount of costs really to seek a therapist, or more blood pressure to support blood pressure medications and things like that. But we're very happy that when there is a crisis, they need dialysis or something like that as a result of years of kind of chronic issues that are largely have been influenced by the lack of access in the healthcare system, to then shell out large sums of money to provide this care. And from a mental health perspective, which is not an area of my expertise, I think that funding preventative, mental health in Ontario is once again a low-hanging fruit to kind of help prevent some of these acute episodes. And I imagine that the person, when they wrote that question, when they talk about the costs associated with schizophrenia care specifically, it's likely related to these acute episodes of psychosis and things like that, where people are being admitted to hospital and things that like, and if we could prevent that and spend funds to provide these patients with the support they need in the community, once again, through access to primary care, through access to psychiatry, through access to other mental health services, we could largely reduce those costs.
Thank you so much. You know what, you got a couple of responses in the chat about this. Let's see. One person wrote to you, Naz wrote to you, Andrew, that great point, Andrew, prevention is better than cure. And Terry Lynn wrote that a patient with mental health issues that has access to equitable care and regular care is not expensive at all. And I think that's true. I mean, certainly that's the case with my brother. Franz, would you like to respond?
About 10 years ago, we had a special committee of the legislature looking at mental health and addiction. It was called the Special Committee on Mental Health and Addiction. Not very creative name, but it did what it needed to do. And basically, the number one recommendation out of this was to create Mental Health and Addiction Ontario, to give all of the pieces that provides good quality care, from health promotion, disease preventions, primary care, hospitalizations if needed, support in the community, all of this together. It was never implemented, but I was part of the MPPs who work on that committee. We did a lot of research as to what exists elsewhere, and the best practice to care for people with severe mental illness really takes into account food and shelter. You cannot provide quality mental health if the person is homeless. You cannot provide good mental health if the person is not fed. They are human beings. So to be able to put a center of excellence about mental health and addictions, to bring all of the different parts, the housing, the revenue, the support, the connections to mental health specialists, including physicians, psychiatrists, psychologists, social workers, etc., bringing that all together, like we did for cancer treatment. Like cancer surgery, cancer treatment, diagnosis, and all of this is all under one roof. We wanted to do something very similar for people with severe mental illness. It never materialized, but we know that this is where the best practice reside, and this is where you're able to keep people with a severe mental illness as well supported and as healthy as possible.
Okay. Thank you so much, Franz. Kristyn, over to you.
Fantastic. And thank you. Just staying on the theme of mental health and mental wellness, addictions, and perhaps recovery. I think this is a very important issue for all of us, because we know that without mental health, there is no physical health. Without physical health, there's no mental health. The two of them are related. And I recall that there was from the Canadian Mental Health Association, they actually came up with a proposal that that there should be equal parity funding when it comes to physical health and mental health. It's not something I believe that we've adopted here in Ontario per se, but perhaps something that our party could consider. Let's put that on the back burner as a potential to do. My question is really about, and this one is definitely for you, Franz, because you're probably our most senior, experienced MPP on the call tonight. There's a request to take a look at spending and perhaps sending some work to the provincial auditor. Neglecting homeless people is costing everyone much more. It comes with unnecessary costs, obviously, with ambulance costs, repeated ER visits, court time, encampments, police apprehensions, you name it. If we don't take care of people's mental health and mental well-being, they sometimes fall through the cracks, and sometimes those cracks are as large as the Grand Canyon. The question is, can the NDP ask the provincial auditor for a review on the type of spending that is allocated towards sort of ancillary care versus actually providing mental health supports, perhaps something that was similarly done for autism services?
Can we make the ask? Yes, absolutely. But we do not direct the Auditor General. The Auditor General is the only one who makes the decision as to what audits she does, except if you have unanimous consent of all of the members of the public accounts, which basically the Conservative members have a majority in the House. They have a majority on public accounts also. So if they don't agree, it's never going to go anywhere. But my experience would tell you that if many of us, and it doesn't have to be MPP, many Ontarian, write to the Auditor General and ask her to do something, I know that she keeps a little file of all of the requests that she receives, and they review those when they decide which audit that they're going to do next. So if enough of us send little, I have no problem sending such a request. But if more than just me send a request, there's more of a chance that they decide as a group which audit they do every year. There's more of a chance that they would pick that up.
Fantastic. Thank you. That's helpful advice.
Okay.
I think we're heading back to you, Chris.
Okay, thank you. We're going to talk about ODS or federal funding. That's the next big topic here. And the reason the question the writer wrote, the reason Canada's health system has worked so much better than the US is that federal funding requires certain core services at least. But many provinces, including Ontario, are pressing for no strings attached funding. Interested in any comments the panelists might have. So what do you think of, the provincial government, Premier Ford is asking the federal government to provide 35% of healthcare funding, but he wants it no strings attached.
I'm happy to kind of start off that piece.
Sure,
I do, I really enjoy that they mentioned the fact that we have, more efficiency in our system than the United States does as well. And kind of a statistic that really comes to mind is when you look at public delivery of healthcare services, the administrative burden to actually administer a private system or a multi-tier system is actually so high that it becomes inefficient. In the United States, 30% of all expenditure in healthcare goes to administrative costs. In Canada, it's 16%, and on Medicare, it's about 1.2%. In Taiwan, where they have a predominantly universal healthcare system, they have the lowest administrative burden, a cost burden in the world. It's less than 2%. So I totally agree. When we talk about efficiency, our system is the way to go. And now, speaking on the actual federal transfer fees to the provinces, I think it's a rich ask to demand for increased funds to fund a system that is essentially broken. We need to really, when we get these funds, in the provinces get these funds, there needs to be accountability and an action plan that shows our federal the federal counterparts what the provinces are going to do actually with these funds. And I think there was a really interesting piece put out recently, really discussing that if funds are to be increased, it needs to be supported by expanded plans to expand team-based primary care, streamline the licensure for international medical graduates, really have a plan, a provincial plan for health and human resource strategies and things like that, before just getting money kind of in a black box and then doling it out to either increase private for pay healthcare or private investor owned private delivery of healthcare.
Thank you. Franz, would you like to respond to that as well?
I would add to what was said that I'm a provincial politician. I know full well that the biggest responsibility of the provincial government is healthcare. They are responsible for healthcare. But Medicare, the program that defines us, is a program that every province, we have the same. We all have hospital, we all have physicians, and it comes from the federal government. I would love to see something similar, money coming from the federal government to say, you have to use that money for pharmacare. You have to make prescription drugs available. we will give you, I don't know how many billions of dollars, but you have to put a mental health strategy in place so that everybody has access to mental health. And here is the deliverable that we want to see, or we will give you more money, but 100% or 99% of your residents have to have access to primary care. How are you going to do this? We want to see more interdisciplinary care, and we want to see this Canada-wide. I think there is strength in numbers. There's more Canadian than there is Ontarian. I think they are part of our healthcare system that needs federal investment, but federal investment, same thing, senior strategy. It would be really cool to make sure that every seniors throughout Canada has a level of care that is clearly defined, access to services, etc., that are clearly defined, and make sure that the money that comes from the federal government, we all know that the money that comes from the federal government come from the same taxpayers that pays for the taxes in Ontario. We all figure that. So we physiologically, I'm not opposed to having Canada-wide programs that don't exist right now. Dental care, pharmacare, mental health, senior care. There are many where the federal government could play a huge role, including funding.
Okay, thank you so much.
Thank you. And Franz, along that same line, I think you know, there's a great question in the chat, and I recognize it's a question that's been asked on several occasions, certainly to myself as a local MPP, about federal funding for healthcare that comes with strings attached. So therefore, some stipulations on how the money is being spent, because we keep hearing, I think we all have, from federal politicians. I certainly have heard it from the Deputy Prime Minister, the Prime Minister himself, that the money has been sent, and then it sort of sits in the provincial coffers while we wait for the province to, the provincial government to make announcements. Is it possible to have some conditions to that funding, Franz?
Absolutely. I mean, some conditions already exist. I mean, if you allow your healthcare to privatize, you're not allowed. People are allowed to go to the hospital, are allowed to see physicians, and it doesn't cost us anything. If you break the rules, there are 5 rules within Medicare. If you break those rules, the federal government has a right to withdraw your money, and you won't get funding from the federal government anymore if you do this. I have no problem having accountability and oversight of what needs to be done. And yes, even during the pandemic, there was billions of dollars that came from the federal government to help our healthcare system during the pandemic that never got spent. Mm-hmm. When we had nurses burning out, when we had physicians at the end of their wits trying to provide care during very difficult time where we needed more money, more resources, the government sat on $1.1 billion of money that came from the federal government for our healthcare system that never reached, or for a hospital that never reached our hospitals.
Thank you.
Mm-hmm.
Thank you so much, Franz. Kristyn, did you want to go?
No, I just wanted to thank Franz for that answer, because I know that on many occasions that question has come up. But you know, knowing that number one, conditions can be placed on the funding, I think is important. The roundabout, of course, is that oftentimes we're told by the federal politicians themselves that they cannot condition the spending, that they can't necessarily force the provincial government to spend it the way they do. So they seem to be talking through both sides of their mouth, and this is why people are confused. Okay. So thank you for that.
Yeah, no, thank you. Let's see. So Elizabeth, I saw your hand was up. If you could type your question in the chat, we'll try to get to it. We're getting short on time. We still have to do wrap up, and I want to be sure to talk about next steps for people, about actions that you can take to help protect our public healthcare system. There is a question in the chat that I'm going to take now from Andrew Yin. Not sure if this has been discussed, but would you say the cost, rigorous admission process, and limited space of our med schools play a role in our healthcare troubles? Andrew, you sort of answered that one. Do you have anything to add to it?
I think in part there's a role that it does play, but the challenging thing is that when we cannot force medical students and medical graduates to practice in certain specialties. There's, a movement that, many people want to be ophthalmologists. Do we necessarily need that many ophthalmologists in Ontario? Probably not. We need more family physicians. We need more psychiatrists, so on and so forth. But it's very hard to pressure medical graduates to pursue specialties they're not frankly interested in pursuing. But I do think that the government can think a bit about how to incentivize people to go into specialties like family medicine, like psychiatry, that we really, really need in our province and across Canada. And we need to be creative with the incentives we provide these graduates in order to kind of expand that those cohorts of those physicians. But it is very challenging, I think, in part, kind of due to the competitiveness of medical admissions in Canada, to really then further stipulate on what kind of specialties people go into. But I do think that there's a role to be played by the government to incentivize people to pursue certain careers.
Thank you. Kristyn, over to you.
Okay, fantastic. Thank you. I'm going to take this question from the chat from Margot. It's a fairly long question, so I think I'm just going to read it out loud. I think the question might be directed to both Franz as well as the doctor. We have healthcare heroes who we have treated badly. We have rewarded the nurses and doctors who got COVID and now have robust, durable, natural immunity, and therefore many who did not get the mRNA injections by firing them. How many healthcare workers have been fired in Ontario? We are short-staffed, so it is only logical to ask these people back. Instead, we're losing them to other countries without mandates. It's a tough one, a complicated one, and you may not have the numbers to how many people have been fired, but Franz, I think you're going to take a stab at this.
Sure. I can speak for my hospital, Health Sciences North, that has about a staff of close to 3,900 people. And there was 89 people who refused to get vaccinated and who no longer work there. The big issue is that everybody else who works there wants to make sure that the people that they work with are vaccinated, because not only does it protect you from getting infected, it also protects you from spreading the virus. So there is still a huge reluctance from the people in healthcare to work alongside people who are not vaccinated. So we've seen a huge exodus of people from our healthcare system right now because they are burnt out, because they are exhausted, because they feel disrespected. And I can guarantee you, if we were tomorrow morning to say, oh, and by the way, you may be working alongside people who are not vaccinated, we would see an even bigger exodus. Just to put it into perspective, every hospital in Ontario, to apply to work in a hospital in Ontario, you have to have at least 12 vaccines to go in. Now with COVID, it's 13, but everybody who works in our hospitals have always been asked to show proof of vaccinations for a long, long list of diseases. Because you are a healthcare worker, it protects you and it protects the people that you work with.
Thank you.
Thank you.
Okay. So we're getting close to the end here. I want to give our panelists an opportunity for closing remarks, and then Kristyn and I will also give some closing remarks. So Andrew, over to you. Do you have any other messages or any other comments for the people who participated in this?
Yeah, well, thank you very much for having us here to chat. I wanted to briefly just address a comment about Bill 7. There was a comment in the chat about creating kind of an independent kind of person to have those discussions, those tough discussions with patients that they have to leave the hospital. And I think for myself, and a lot of physicians, the biggest issue is that almost 100% of Ontarians and elderly people across Canada, when they're actually surveyed, they would like to, age gracefully and receive care in their homes. So I think we really need to be funding home care and supporting these individuals to be at home and not pushing them out of hospitals into long-term care homes in different communities that they're not a part of. But from our perspective and at Canadian Doctors for Medicare, we put out I put a link in our chat to our website, but we put out a group of physicians put out a call to the Premier and the government about certain reforms that we think are actionable and can be implemented quite swiftly that would help kind of alleviate some of the pressures in our healthcare system. Number one is really starts with repealing Bill 124. A recent survey showed that the primary reason that nurses are leaving the profession is really wage dissatisfaction, about 91%. And really, if we could eliminate that bill, that would be a very good starting point to help retain some of our nurses in the profession. Number two is really invest in not-for-profit delivery of care, not for profit, like many members of the government are advocating for, but really the results do show that for-profit entities really do have worse health outcomes. During the pandemic, the for-profit long-term care homes had 78% higher 78% higher mortality rate than their not for-profit counterparts. So that's a thing that we really need to be advocating for. Number three is really repealing Bill 7. It's going to be sending frail, elderly people and people with disabilities to long-term care facilities without their consent, and they're really being coerced because they don't have the means to pay for extended stays in hospital, but they also don't want to necessarily leave their communities. And really repealing that and focusing on bolstering our home care kind of programs is the way to go from that perspective. We really need to invest in primary care in order to support physicians and also patients to access primary care so they do not have to use the emergency departments as their kind of last resort to seek the care they need. And that will help lessen the strain on our healthcare system and improve care in hospitals. And really lastly is in the context of the RSV kind of virus surge in pediatric populations, in the context of the COVID-19 pandemic that continues to rage on, we really need to be forceful with our measures to control the spread of infectious diseases. We need to really advocate and be proactive with measures to help prevent the spread of these infectious diseases into the winter months, and really bring back mask mandates. Largely that's kind of what many physicians and health policymakers across the province are advocating for, and we need to push the government to kind of implement these types of things.
Okay, thank you so much, Andrew. And thank you so much for being here. It's a real pleasure to have your a real honor to have your expertise, and thank you for taking the time to spend with us tonight. Franz, would you like to say a few words?
Well, very few. Medicare is a program that defines us. As a Canadian, as an Ontarian, I get care based on my needs, not on my ability to pay. Ontario is the province that have privatized the biggest parts of our healthcare system. Home care is now owned mainly by big US company who gets contract. The majority of our long-term care beds are owned by for-profit company. Now the government wants to open up private surgical suite. They say there's such a big wait time for surgery. Let the private sector open surgical suite. The problem is we don't need more surgical suite. We have operating room. We have surgical suites in our hospital that sit empty throughout our province every week. The reason not enough people to provide those surgery, and not enough people to look after you after you've had the surgery. It's not the installations that we need more of, it's the people. The problem with privatization is that I guarantee you, they will find a way to charge you for something that is not covered by OHIP, but you really have to pay for when you go to a private clinic. The rest of the people who cannot afford those extra fees will end up waiting longer, and the health human resources crisis we now face will only get worse because we won't create a new physician. We're not going to create a new OR nurse. We're going to take them from our public system and hire them into a private system, making our public system, who needs to be there 24/7, because you don't always choose to have an accident on Monday morning. If it happens on Sunday or Saturday midnight, they will still look after you at Saturday midnight if you're lucky enough to need this. So we have to be very loud about telling Mr. Ford that we don't want any of this privatization of surgical suite. That's not the way to address the backlog of surgeries that we have now. The way to address it is to be respectful to the people who do that work. Number one, get rid of Bill 124.
Okay, thank you. I'm going to just say a few words, and I'm going to pass it over to Kristyn for final comments. I think you're right, Franz. Public healthcare is one of the services that defines us in this country. And Tommy Douglas was rated as the greatest Canadian. And I think it just speaks to the sense of community, you know, that we in Canada are one community and everybody has the right and should be able to get the medical care that they need when they need it without cost. And I think that it is such a defining service in our country. There were 4 things that people mentioned during our, well, 3 were mentioned. I'm going to add one more. 4 action items that you who are listening in tonight can take. The first one is to wear a mask. Christina mentioned wearing a mask, not just to protect yourself, to protect the people around you and to protect our healthcare workers. The other one is to get vaccinated. I know that I'm due for my next dose. I was looking online today to find places. There are lots of places to get doses, and you can usually book them same day or the next day. So get your vaccination. And the third thing is to sign the petition. We'll put the petition back in the chat. And the fourth thing is to stay vigilant. We need to protect our healthcare system. It is under threat of privatization by this government, and we need to fight to protect it. So also attend the Ontario Health Coalition town hall that's coming up. And thank you all so much for being here tonight and showing your interest and your concern about Ontario's public healthcare system. And Kristyn, over to you for final words.
Thank you very much, Chris. And I just also want to associate myself with those remarks, and especially with the gratitude to our speakers, Christina, who left us a little bit earlier. Much thanks to her. She was running off to a shift. To our health critic, Franz Gelinas. Always a pleasure to hear you speak. You have such incredible knowledge about the subject. Cannot wait to see you as our health minister one day, and I know it will happen. And of course, to the good doctor, thank you for all that you do, and especially around the public awareness and the promotion of making sure we have a strong Medicare system. I'm going to leave people with an inspirational note. I felt like last week might have been the longest week of my political life. I've only been a politician for 12 years, but it was big. And it was big because we started the week off with a bit of a lull because we had the notwithstanding clause and we had a big struggle. We walked into that week with a lot of anxiety. And then we saw the labor movement unify and come to Queen's Park, but also across Ontario. Everybody stood up and said, we don't like it when people are being bullied. We don't like it when people are mistreated, and public education is important to us. That sent a really loud message to Queen's Park, and lo and behold, Doug Ford, who never backs down on just about anything because he doesn't feel like he has to, he's always in control, he's the big man on campus, he was all of a sudden made this big. And that's because people took their power. So if this issue around Medicare and publicly funded healthcare is as important to you as it is to me, then let's fight for it, because it's worth fighting for. If that's what defines us as Canadians, then I don't want to be defined by anything else except for the fact that we have the best Medicare system on the planet. I think that's what we deserve. So thank you very much, everyone. It's so great to have you all tonight. Thank you. I know for those who are home, then please enjoy the rest of your evening. For those who have to get home, and I can see that both MPP Glover as well as MPP Gelinas are both at Queen's Park, please get home, everybody. Get home safely.
Thank you, everyone. Have a wonderful night, and thank you for being here.
Take
Thanks,
care.
everyone.